During 2017, I participated in an innovative rehabilitation program for complex post-traumatic stress disorder. I came away with an unintended, remarkable body of painting works and greatly improved quality of life. My background as an artist, creative arts therapist and medical scientist enabled me to invite my treating practitioners and colleagues to come together in fostering education and conversation about the sensitised central nervous system and my recovery. Here is one of several offerings.
Central sensitisation really needs to be explained just briefly within the context of what happens with normal pain. So the central sensitisation of pain. So when a healthy human being experiences a painful episode or a painful stimulus, that is normally dealt with at the point of where the stimulus occurred, on the body or in the body. And then it's processed and largely attenuated. It's dropped down in its intensity so our brains can make sense of it. So it's not just the sensory experience, it's relating that sensory experience, whether it's painful, in this case it's pain, and then putting that alongside of previous memories of that experience, putting it alongside of what caused it, where in my body it is, and so on. So we don't want to have a massive amount of overflow of that experience because our brains can't cope with it. So along the pathway from the part of my body to my brain, it's largely attenuated or integrated, okay? When we have someone with central sensitisation, it's amplified. So that painful experience or that nociceptive experience is actually amplified as it passes from the receptor, which could be in my skin, it could be in my gut, it could be in my heart, it could be anywhere, it could be in my eye. That is then, rather than attenuated and integrated to allow it to be packaged for my brain to make sense of it, it's actually amplified. That amplification then repeats, develops plasticity within the system. The networks that normally deal with this, the neural networks in my brain, suddenly shut down or are disengaged, and other networks, fear of the pain, the relevance of the pain, the importance of the pain, start to actually take over. So when you first arrived and you first came into this room, and you were lying on this table, it was very obvious at that time that I wasn't able to actually really touch you. Because at the time, any type of sensory stimulation to the surface of your body was causing you pain. Now, it didn't matter whether it was a tissue paper touching you, whether it was just my hands lightly touching you, you were going to have a painful response to any type of what's called somatic stimulation. And this is a problem with a lot of patients or people who are centrally sensitised. That term is allodynia, A-L-L-O-D-Y-N-I-A, so allodynia. And you were suffering extreme allodynia, and that's considered to be a hallmark symptom of central sensitisation. So the dilemma is always going to be, as a body worker, I'm going to go and do the stuff I do. But in a case like you, and you also had a history of people who had tried to treat you, that you are having considerable post-treatment painful responses, and then you were developing fear about it. Okay, so what we try to do, what has been suggested, is that we try to do a treatment of tactile desensitisation. So what we try to do is identify the various types of nerves that are going to respond to different types of touch as such,
Yeah.
and work our way gently through those. Yeah. However, there's a couple of things that we have to be aware of. So one is that if I do touch you at first, and it's a novel touch, in other words, you've no idea what's going to happen, most people will have a response to start off with. So I do touch you, and there might be a little bit of a withdrawal or whatever, but when I go to do it again immediately, your frontal lobes, if they're healthy and working well, will actually now incorporate that and predict it and understand that nothing bad's happening. So the initial fearful, reflexogenic withdrawal response that everyone wants to do, like what's that, okay, in a healthy person is now subdued. Now that's cortical pain modulation. Your frontal lobes are activating all sorts of pathways that are now descending down and saying, it's cool, don't worry about it. So in a healthy person, which we can usually, we do it again, and you say, oh, that doesn't bother me. In a centrally sensitized person, the next time you do it, it's worse. That's called temporal summation. So with time, the event summates in your central nervous system, and because you don't have the great ability to inhibit that through your frontal lobes, because they're starting to, well, they're not going so well, each time it's done after that, it gets worse. The experience someone lives with having central sensitization of pain, particularly, is usually an amplification of many different types of sensations. So it might not just be pain, but it might be light, sound, and so on. So first of all, the sensory world can be very much amplified. Then confusion can occur that other sensory experiences may then be misinterpreted as pain. That's number one. The difference between pain and suffering is something that philosophers have been dealing with for centuries. Until, so my suffering will escalate, perhaps in the absence of an escalation of actual pain. So suffering becomes an issue about how I live my life, how I relate with my family, other members of society. So there's already a relationship issue about suffering. Then how I actually communicate my suffering to my family members and the people around me becomes a really big issue. So I move to a behaviour which may be amplified, again, beyond the pain and beyond the suffering. It may be a behaviour that is associated with the avoidance of having any more of this happen. An unwillingness to engage in the world, an unwillingness to understand the perspective of other people, an unwillingness to sacrifice myself for others, because the egocentricity of a chronically centrally sensitized person really starts to dominate the community in which they're involved. So life changes, your condition starts to define you, no one finds an answer, you're being told that maybe it's in your head, and it is, it is to a degree. After that, of course, the researchers discovered or suggested that childhood traumatic experiences may have fed into disrupting the normal perception networks of pain, conditions like sexual abuse, physical abuse, medical interventions as a child, having something serious like being hit by a car, going through a range of medical interventions as a child, may also have set you up. So the other issue about this is a person eventually may start to realise that their condition may not have occurred at the time of the injury, because normally there's been an injury that's prompted this in the first place. They may have to start reaching back and unravelling issues that might have occurred prior, well prior, which might have appeared to have nothing to do with the actual injury. So, and particularly, sexual assault and sexual trauma is probably one of the biggest issues that cases with central sensitization may have to explore. To me, that's the life of a person that's really suffering deep, unresolved, chronic central sensitization. So, we've got a dilemma as a therapist. How are we going to actually deal with this? So what we've got to try and do is ask you to, or tell you what's going to happen. I am going to do the following. Then in this technique that I use, I ask you to repeat what I'm going to do. So not only am I going to ask you to repeat what I'm going to do, I'm going to actually tell you where I'm going to do whatever I'm going to do. And you have to actually repeat that again. And then I asked you very specifically, I told you to repeat, I'm going to touch your right big toe on the toenail side of your toe with a piece of tissue paper. And then you would say,
you're going to touch me on my right
good,
toe,
so you remember it.
part of the
So, and I would say to you, do you think that should hurt you? And you would look at this and say, no. Okay. Now I also got you to do it with your eyes closed and your eyes open. We know that when you do it with your eyes open, you're actually preparing. It's a much greater cortical event, a frontal lobe event. So you have a chance of actually setting up central pain modulation. Okay. So as a test as well, I'm able to ask a person to close their eyes, and then you've repeated what I'm going to do. I then do it, and then I ask you with your eyes closed to tell me what actually I touched, and you will say, you touched me.
On the right toe.
Good. And then I asked you very quickly, was it painful? Did it hurt? And of course your answer in those early days was yes. Okay, so this is not going to be good. Okay. However, I asked you then to open your eyes and repeat the same thing. It was a laboriously, painfully slow process to go through. We also only used the surface of your body from your knees down and your elbows down. Now we know the reason for that is because these surfaces, what we call distal or lower than the elbows and lower than the knees, is mapped in a very specific part of your brain that doesn't get too confused with other areas. Now your trauma had also been involved in truncal areas, so these areas had held a lot of issues as far as memory. These areas map to an area called your parietal lobe very specifically, so you can actually identify it, you can localize it, you can say, that is my big toe, and so on, though you couldn't do that very well to start off with. If we start to actually work on the trunk, either back or front, that maps coincidentally or collaterally to another area called the insula, and that insula is very heavily connected to your limbic system, which is connected to your amygdala, which is where fear and all those memories are actually held. So it's a problem when body workers and somatic therapists, of course, naturally just go to a spine or go to it, and that patient then can either relive or have confusing experiences after the therapy, and it can be then interpreted as pain. Now you were in an enormous amount of pain, but you didn't have any, like it wasn't as though you had cuts on your leg or you'd had a bruise or you'd had anything. Your pain was now centrally amplified. It was so centrally amplified that you were unable to actually use your frontal lobe to actually inhibit it. So I could have then asked you, I could have said, I'll give you $1 million if you just put up with this. And most people would. You would have a nice frontal, okay, there's a good reward about this, I'll put up with it. But you had collapsed to such a degree where no reward, in actual fact, it was more a reward for you to not have it done. And that's one of the another very significant seminal response that most centrally sensitized patients will have. Their reward is to move away from the threat of having pain, rather than have a reward about putting up with the consequences of it. Okay, so you can't even say, well, if I do this 3 or 4 times, I'll get better. You don't see that as a possibility. You just want to move away from it. Probably central sensitization, if you look at the literature, rheumatologists were dealing with a condition called fibromyalgia, and there was a lot of controversy, confusion within the rheumatology profession. So a rheumatologist in the United States, Muhammad Yunus, I think is his name, I've got to be careful about that, but in 1981 he looked at the comorbidities of, in other words, the other conditions that were presenting alongside fibromyalgia, because at that stage rheumatologists were largely dealing with it as a rheumatological disorder. He wrote an article and presented actually an original piece of research where he looked at 50 cases. Not much happened after that, and then out of the blue in '83, Clifford Wolfe wrote an article, and didn't reference Eunice at all in actual fact in that article, describing as a physiologist, as a neurophysiologist and a neurologist, that there may be a situation where pain is now amplified centrally to cause chronic pain. So I do get an injury to a limb, it doesn't resolve. For some reason, the input, the nerve input that is going along that sensory nerve reaches the central nervous system, maybe the spinal cord, and for some reason it's amplified at that point. From there, Eunice, Wolfe started writing a lot of articles. Through the 80s and 90s, there was an increase in research looking at this. And then by the time the 1990s came, there was a big explosion in brain research, imaging, so the PET scans and the functional MRIs emerged to start seeing changes represented by PET scans, for example, and functional MRIs, that there were brain differences and network differences going on in people with chronic pain. So once they started to identify what parts of the brain these little different colours were actually indicating, and they started to look at normals and then look at abnormals, they started to identify things like salience network. So a salience brain network, what's important, you know, what should I be attending to? They started to look at default mode networks. What am I like when I'm just relaxing and not thinking about much? What am I like when I have an anticeptive, an antinociceptive, a network that actually is able to inhibit pain, like the reward systems and so on. So very quickly that information started to come out, and then for someone like me, the physiotherapy profession, Nijs, which is a Dutch physiotherapist in the early 2010, around about 2010, a couple of other guys, an Australian physiotherapist, and I'll think of his name in a sec, who's very well, Noel Mosley. Mosley started to work on brain and so on. The guy that the man that was my professor, a guy called Ted Carrick, started to really change a lot of my profession about looking at brain as being maybe the central way to approach patients with chronic pain, rather than it being a limb area. So in our area, in the medical, biomedical, allied health professions, that's the way it emerged. Right up to, again, Eunice writing a big paper, a big paper describing it again, reviewing it. Wolfe wrote another big review of it again back in 2010 or 11. So, and boom, then we emerged with the central sensitization inventory. Researchers have been looking at chronic back pain over many years, looking at questionnaires about fear and so on, started to realize that maybe we could combine the various types of symptoms that people are experiencing to see whether we can try to almost objectively measure and rate a person to see whether they fall into a chronic central sensitization. And that central sensitization inventory was developed and published in around about 2011. It's been continually tested and it seems to be fairly predictable. So now it's at a point where if you understand that the system can summate, I can do a stimulation and I repeat the stimulation. If it doesn't get better, it's getting more and more sensitized, then that person may have that. If they can't inhibit pain, they have a history of some issue, they have other autonomic signs, and then they have a central sensitization inventory score over 40 percentage points, then you really should start to treat that person as though they've got central amplification rather than a visceral problem or a body problem, which is, so hopefully you avoid unnecessary treatment. From there, pain neuroscience education became very big. if I can actually explain to my patient what's going on, if I can inform their frontal lobe of what's actually happening, that this is not a tumour, it's not something serious, you're not going to die from it. If I can educate you about that, at the same time getting you to maybe go through some desensitisation work, and at the same time to start getting you up and moving, then the research has shown that people can move away from the centrally sensitised state. And in my practice, that largely works. Compliance is the big issue. So we were talking about this earlier, that a patient, a client must buy into this. The therapist, no matter who they are, is really a facilitator of the client's progress and process and journey, not the actual giver or taker of anything. So, manual therapists are finding that difficult because we're usually used to, or medical people are usually used to doing something, and the client is a passive recipient of what I do, rather than a collaborator in the actual process. So that can be a big issue as well. So that's why I think there's a lot of resistance to this, because normally you take medication, you take a painkiller, you take a drug that changes your brain function, an anti-epileptic or an antidepressant, and everything will be fine. But largely that doesn't seem to be working. There's something controversial. Anyway, so yeah, so that's probably where it's got to now. I don't know where it's going. It'll be interesting to see where it goes. I just think recognising that various conditions will have a component of central sensitisation is not a diagnosis. It doesn't stand as a diagnosis of itself, in itself. It just stands as a state that the nervous system has got to, which is facilitating a process that is largely unresolved. How you go about treating that, there's many different ways that you can actually help a patient or help a client deal with that, from counselling to shining a light in their eyes. So there are many different ways of approaching it. That's why there's a lot of people treating these types of conditions. There's no defined, researched, dead-on, 100% way of helping patients, and there is no protocol. It's largely iterative, or it's largely a process where therapist and client have to work together to find the best way that suits both of them to help the client through that journey. It was all very well doing tissue, but eventually we had to move through light touch, deep touch, light pressure, deep pressure. Then we moved to actual pain receptors. Now, the Latin for pain as such is noci, so nociceptors sit in your skin. So that's when eventually you were able to put up with a pinwheel being done. Now, you were pretty bad, so in many cases we actually start off with a pinwheel, and we see whether, and that pinwheel it's a prickly feeling, but most people put up with it. If you're temporally summating, we do that, and you have an echo that might last for 2 days after it. So you'll ask a person, do you still feel it afterwards? And they say yes. And then 5 minutes later, a patient like yourself will go, it's even worse now. And then it's distressing. So one sweep with something like a spiky wheel, one of these wheels, the Wartenberg wheel, can really create enormous problems. Well, it did with you very early, so we didn't repeat it. So that's the sensory. So we started through, I worked out some areas to do either right or left of your body, because we did feel at the time that right brain was not, that right hemisphere was not working very well, and that's, the research does tend to tell us that the right side of the brain doesn't work as well, and that's where we map ourselves, our sense of self, our sense of body, our sense of where you are compared to me standing next to you. So even me getting this close to you in those days was not a happy thing. The sensory experience of, say, touch, the surface of your skin, is one sensory experience, but of course we are sensory beings, so we're going to have things like smell, we're going to have things like sound, light, taste, and so on, and gravimetric balance. So that's why you ended up doing a lot of those eye movements and so on. But we work our way up to those. Many of those sensory inputs will create an autonomic response. Now, so that means that if I do something to your body, your brain will actually mobilize immediately a heart rate response, a blood pressure response, pupils constricting response, and so on. These are all called autonomic responses. Now, in centrally sensitized patients like you, feeling nauseous, wanting to be sick, and so on is often a common experience when you're actually starting to treat someone who is severe as you. Okay, so that's why we do it very slowly. We maybe ask you want some water, we have to stop, we took you into the other room, you lay in there for ages. For you, the important thing was that you knew what to do, you had an explanation, and you were able to go home and do it. And you did, so you went through that for a long time. So that was a summary of the sensory component of it. Then we had to actually go through the motor component. Okay, so the motor component meant that you couldn't, you found it hard to walk because your brain had shut down. Even taking a step forward was going to be a potential threat. So everything was threatening. So the part of your brain that controls the automatic motor system, just doing something, was now being taken over by the part of your motor system that is going to protect you. So if this is a snake coming up to you and is about to bite you, you're going to withdraw. If you perceive this particular sensation as having the same impact to you as a snake bite, then you're going to the same way withdraw. So similarly, we had to actually now take you through some guided motor imagery where we had to say, right, I'm going to move your foot. I'm going to move it up. I'm going to move it 5 degrees. And actually, we didn't start with your feet, we started just toe by toe. So I passively moved your feet, then you actively moved your feet, and then gradually you were able to build in some exercise, because we know that in order to really overcome this, you're going to have to start moving. You're going to have to exercise, I hate to use the word normal, but more normal motor patterns that are free and you don't have to think about it, as opposed to every particular movement you're doing is aiming to actually stop or prevent or avoid the potential of pain. Certainly the emergent language to describe the model that different professions would apply or have underpin their applications is pretty significant. If you're dealing with, say, a allied health medical therapist, and I would throw physios, OTs, chiropractors, osteopaths, and so on into that basket, then you're going to be really talking about an applied neuroscience at the moment language. So the dominant research has come out of the applied neuroscience or neuroscience literature. Things like temporomandibular joint or temporomandibular joint disorder or temporomandibular disorder, TMD, is a central sensitization condition. So the dentists did a huge amount of research in the 2000s, which emerged out of what's called the OPERA study. So they looked at the genetics of it, they looked at the health behaviour, the psychology, they looked at the neurology of it, they looked at the brainstem, the brain, the networks, and so on. Huge amount of research came out of that, which really prompted a reinvestigation across the board. That profession very much reached into the biomedical, from the genetics of it, as I say, right through to talking about things like the trigeminal system, which is very important to head pain, and looking at the brainstem and looking at interfacing neuronal pools and networks that were involved in giving this pain. Certainly at the moment, in the biggest bodywork therapy group that's been doing the most research is the physiotherapy profession, especially in Europe, and they're using very much the Moseley model, which is brain applied neuroscience. So you're going to hear terms about the parietal lobe and the cerebellum and the thalamus, all these various areas in the nervous system that have different responsibilities for processing sensory and motor and emotional and so on. So I probably link to that language. My applied neuroscience training has been very much along those lines. I, Paul, am going to touch your right big toe on the toenail surface of that toe.
You're going to touch my right big toe on the toenail surface of that toe.
And do you think that should, with a piece of tissue, by the way, piece of tissue paper? Good. Do you think that should actually hurt you?
No.
No. Okay, and that was your response too, by the way.
Yeah.
Can you tell me what you felt?
Just felt a light touch on my right big toe on the toenail side.
Great. That took about 6 weeks to get her to that stage.
Yeah.
I'm going to touch the outside of your left lower leg with a tissue paper.
You're going to touch the outside of my left lower leg with a tissue paper.
Now the idea of this was to get you to actually localize the part of your body, so you started actually to connect with that part. So terms like left, lower, outside were really, really important for you to cognitively actually create on your body where this was going to happen, and to predict it, and predict it safely that that's what was going to happen. Okay. Now, after a while, I was able to just go along with you and say things like this. So when you feel tissue, say yes. So close your eyes.
Yes, yes, yes.
And we would have done the same thing with your hands.
Yeah, yes.
Did any of those cause pain?
No.
No. Good. So gradually, without you knowing what was going to happen, I was able to just spontaneously have a new or novel sensation for you, and you did that. Language barriers can create an us and them between, you know, partners in a therapy for the patient. So the patient is often the one or the client's often the one trying to describe to another therapist what that other therapist is doing. So they find themselves being an advocate for a therapist that might be a little bit, you know, boo-hooey from the therapist they're in front of. Well, I'm seeing the craniosacral therapist, I'm seeing the arts therapist, I'm seeing the psychotherapist. What did they say? Well, often the therapists themselves won't call up and actually talk to that person, because they have to establish a new communication line takes a bit of an effort. It takes effort outside of the therapeutic consultation, so I imagine that costs money for all of us. It's time, there's patience. I don't have time, I've got my life to live as well. Do I need to be spending time talking to another therapist about something? Luckily for us, I think we do have people that tend to reach out from professions and make links. So I know that if you're in the game long enough, I'm not saying that people who don't do this don't care, but if you care about your patient enough, I think you'll find therapists do reach out if they've got a serious interest in this. So I think for clients and patients who might be listening to this, if you push your therapist hard enough, they will actually reach out and make those connections. It can be difficult. It may not solve your problem when you're, you know, the patient themselves right here and now, but for the future, if you push, people are happy if they can just overcome the language barriers, which are cultural, by the way. So it's not just a language barrier; it's a cultural difference. The way we approach, the way we deal, the way we stand by a patient, where we sit on the table, on the other side or on the same side. You know, the psychosocial model to the medical model. There's the big difference. So I think we do find that the medical model, they seem to hold their own language and are very reluctant to speak any other language. Okay, like first language English speakers. But you'll find that other people are prepared to maybe, you know, change their language to integrate someone else's approach. Then we go to light pressure. So or light touch with my fingers. Now, one of the other aspects of the problem here is that when we have an inanimate object touching you, that's different to another human touching you.
Which we did do. We used spoons.
We used spoons, we used a whole range until I was able to get to the point where I could actually touch you. Yes, definitely. I'm always now aware that people in chronic pain are certainly undergoing and undertaking other therapy. So that's number one. And I'm very keen to reach out to everybody. Now, I've always been a bit like that, but even more so with cases like this. Dealing with trauma and having that appropriately dealt with, any type of emotional trauma in a person that is unresolved or is being resolved. It's very important, as we found out, that to know when to hold your care and when to administer your care, and to have your ego parked a long way away, because really the patient is central to this, the client is central. Listen to the client, and then hopefully, that being able to do that. Sometimes all that can make it more confusing. It's easy when I've got A to B to C to D. Makes life very easy. It's a straightforward process in a therapist's mind, but when it's A to Z and then Z to M and then everything has to change, it becomes more complicated. So it certainly taught me that the journey can be complicated, but don't make it too complicated, but it can be simple as well. But be prepared for whatever is going to happen. And as I've just recently lectured, to say it's not about you. The patient has full control over this. When the client wants to stop or go or not go, it's really it's their call. Is that still feeling tingling?
Not really.
No, so it's pretty well gone.
Yeah.
So in the early days, that was a very unpleasant. Unpleasant is the word that's typically used, and it lasted for quite some time. In cases like you with high central sensitization, you can start feeling quite nauseous from this. Your heart rate can start going. A small, simple, innocuous, nociceptive input can have a very significant hyper-autonomic response. So your autonomic system is very dysregulated, and that is one of the problems that we have when people go home to do routines. They won't work through the first few days because they feel sick or they feel awkward, they feel not well, and therefore they tend to stop doing it. I think the Colour by Numbers project is clearly a vehicle to share and collaborate, not just by exposing this to potential clients and patients who may benefit from collaborative approach to their condition. But I think it's really important that it's for therapists as well. I think, I don't think it's accidental. I think you've been through the process you've done, for a reason. But it's a perfect pivotal point opportunity for people to come together with, in safety, without ego, in a collaborative listening environment, to share their experiences and know that as a therapist your experience is valuable. Okay, that's really important. Don't think it's not valuable, but also make sure that you don't think it's more valuable than anybody else's, no matter who they are. Also, that the patient's experience, the client's experience is more valuable. Sometimes you can centre it around the therapist. As a therapist, you can centre it around your own experience. So the value out of this for me is to make sure that I don't juxtaposition my own life experiences, and no matter how long I've been, when I'm about to see a patient. That's really important. Abandon it. Use it later on, but do not think you've seen everybody, you've seen everything. Every client sitting in front of you is a new experience for you to learn. And then, because that's what this is about. This is about bringing people together. You've got leverage. I think the biggest issue here now for me is that I might talk to a few people, but to be involved in this project and have an ability to have leverage about these types of messages is really important. I didn't think it would work out this way. So there's the other thing. You throw a pebble in the pond, but you don't expect it to turn up in Western Australia, So that's also another issue. You never know. Put yourself out there and you never know how it's going to turn out. Okay, so I'm going to ask you to keep your eyes focused on the central dot. You're going to be moving horizontally. So you're going to take your nose towards the left one and then slowly back nose through the central one while you look at the central one, taking about 5 seconds just to move to the right. And you're going to do that 3 times going horizontally. Once you've mastered that, then we're going to ask you to do exactly the same in a vertical way. So you're going to take nose up to here while you keep your eyes on the central one. You're stuck in your obsessive, so you're going to go from here, keep your eye on the central one while you move slowly down. Okay, and then up you go again. Emerging out of my experience with you was the fact that I have been doing postgraduate teaching for quite some time, but it's always been curriculum based. I think in cases like the chronic pain that you are in requires a therapist, no matter where they come from, to have a much bigger understanding of the world around them. So out of that, I decided to develop an educational initiative called the Trophic Factor, which is, in medical terms, means growth factor, because I feel that more and more complex cases like yourself are being dealt with and approaching therapists out in the burbs as such. They're not getting the work or the treatment or the resolution they thought they would within the institutionalised medical system, and so they're moving outwards. So they're landing in the offices of people perhaps really who may not be able to cope with them, which is a sad thing because they could, but that ability to cope means that they need to have more than what they learn at college, but do they need 35 years to actually work it out by first principles? So there's a lot of education that is between the lines that, when you're trying to study for something, all you're trying to do is pass those exams. I think life as a therapist, no matter what kind of therapist you are, is a hell of a lot more complex than it was when I graduated. Trying to pass down that wisdom, I know that's a bit of a trendy term at the moment, or that information, and help therapists, no matter where they are, grow quickly, a little bit quicker than what we were allowed to do when I graduated in the 80s, I think is really important. So the opportunity came through chronic pain. So once I worked with you, I then had a bit of a think, well, does everyone have to go through these accidental, meetings of minds? Does everyone have to go through that process to learn? No. We all have to go through our own personal experience, but if I can maybe help people get a better understanding of some of the things that I've been through, with some theoretical constructs behind it, so a little bit of research and so on. I am involved in research, in clinical research, so it's good to see if I can combine my understanding of years of experience with theoretical applied neuroscience, with my meeting of other people from other professions, and try and bundle it up to something that is into an educational process with people. That's what I'm trying to do. So it is early days, so I don't know how that will go over the next year or so, but we'll see how it goes.